So that's rights and values, ethics, general distinctions, ethics and morals. All of these things don't have one working definition, which is great for people that are involved in ethics. I was at a meeting last week with a director of a facility, and he said, you ethics folks are all the same. You come in, you give us lots of great information and support, but you make no decisions. You just ask more clarifying questions. You got a great job. But part of that is that it's not easy to nail down or provide definitions for some of these topics. But generally, ethics has got something to do with an examination of actions or behaviors or And it generally considers both the content of these actions. So the content would be, what are the values? What are the values present, or what are some of the principles present in some of these actions? And it's also concerned about the process. So we might not sometimes be able to change the values. I can't necessarily change the fact that I would love to have my kids safe at home in the house, but they want to exercise their individual autonomy and freedom. I can't really change the content of that and the fact that that's going to be a regular balancing act for me, but I can change the process. I can change how I approach them. I might not have my angry face on. I might have my calm face. My youngest, who's now 13, started at a very early age, and I think she got this from her older sister. She always used to say, "Calm your face, Dad." And that's a really good response to a process issue. So ethics is concerned about content, and it's concerned about process. It's also concerned about options and generating options, and those options might not necessarily be about what is right and what is wrong, or what is ethical or unethical, but what is more ethical, or what might be more right in a particular situation. Lastly, morals. Often ethics and morals gets used interchangeably. I like to make a distinction, and the distinction that I like to make is that morals tends to be more personal. It tends to be more internal. It's the thing that happens inside of me from the top of my head to the tips of my toes. And it's not me that's made this distinction. People that are a lot smarter than me have come up with this. One person is Rosalie Starzomski, who's actually a nurse. She's from Cape Breton. She teaches at UVic, and she talks a lot about morals and moral distress as that thing that we experience inside of us. And that moral distress is actually an occupational hazard in healthcare, because we're in the business of being in complex places and complex situations with people, and we feel that inside of us. So that's a topic for a whole other lunch and learn. It's very, very fascinating, and she's done a lot of great work. And then it's been picked up in the U.S. by another nurse by the name of Mary Corley. So the role and function of rights is generally got more to do with the law. Values, some of those enduring things. Those enduring beliefs that we all have. Ethics is generally outside of us, and we can examine it, and we can examine it according to the values that are involved in the content and the way that we approach it, or the process. And then morals is generally inside of us. So risk. What do you think is risky behavior in long-term care? We're dealing with a seniors population here, and so I've got a few pictures. And I had a bunch of other ones that I just didn't have time for. But I'm just going to ask you to consider these pictures. Do you consider some of these behaviors risky or not?
Can I see them?
Yeah, they're coming up there.
You switched it to show you, so I'm just double checking to make sure that they can actually see them.
There's one of them. So here's someone driving a motorcycle without a shirt on. He's got a helmet on, no shirt. Is that risky behavior? Is this considered risky behavior? I was involved in a case last spring in long-term care where this was one of the behaviors that staff was struggling with. And it was a 4-lane highway. You don't need a license to drive one of these things. I've always wanted to drive down the yellow line on a highway. How about jumping on the bed? Raising the roof. Fairly risky behavior. This one says, her hat says, "We'll knit for sex." So is it risky behavior to be providing a service for sex and or advertising for sex? And what level of risk are we willing to tolerate? This is my favorite one. Actually, somebody first sent this to me and said, "Dave, you heard about the shipbuilding contract that Nova Scotia was awarded. Well, I just received a picture of the new icebreaker." And then when I opened it...
Would Cody Mansfield and Mum please return to outpatients lab? Would Cody Mansfield and Mum please return to outpatients lab?
Did everybody get that? Cody and Mum, please return to outpatient lab. So this is one of the new Canadian Coast Guard cutters, icebreakers. Risky behavior. So what is our role in risk? We all tolerate risk. We all live with risk. And risk, like other things in life, is one of those things that change from person to person and from situation to situation. So when I think about risk in long-term care, we are all care providers. We got in this business generally because of empathy, that we wanted to make a difference, that we do want to care for people. We're also in this business because it's a good job and we got good benefits and good perks. But generally, we want to make a difference in people's lives. And so our roles are generally divided around professions: nursing, nutrition, medicine, psychiatry, recreation, occupational therapy, physio, spiritual care. What do we bring to these roles? I want to suggest, and again, it's not me that's put this stuff together, the literature and experience, that we all bring values. So all of us have our values. We would all value health. Some of our beliefs around health probably differ. Some of our beliefs around care probably differ. And I want to suggest some of our values around risk would differ. All of us would never want to place somebody that we're caring for at greater risk. In fact, I would suggest that we all want to be very competent so as to minimize risk or potential harm to folks, and actually to provide the most benefit. So we all have these values, experiences, and skills, and they come from three spheres: our personal sphere, our professional sphere, and our organizational or community sphere. I often like to describe these as different worlds and or circles. And so inside of these different circles, our personal circle, our values, experiences, and skills, such is the case as well professionally and organizationally. Sometimes these three worlds line up and they overlap. So the tension between our personal values and experience and our professional and organizational value and experience is not that great. At other times, they're pulled apart and they may not even be connecting, which can cause an ethical dilemma or even ethical distress. Hopefully this makes sense. So at the table, at the bedside, whether you're in the boardroom, the nurse's station, the chapel, the exam room, we all have personal, professional, organizational, and communal values. And they vary based on our experience and our skills. So this is some of the currency. This is some of what's in the room, that we can actually examine this. We can examine the content of it as well as how we deal with it. And that's what ethics is about. So what are some of my roles as a healthcare provider? It's to provide care and service. I want to suggest that related to risk, it's to assess for related and our potential risks. So with respect to our case of Fred, part of what we would want to be assessing for is his risk for choking, his risk So his ability to be able to swallow, what kinds of foods he can swallow. Is this an episodic thing? Is this something that just happened once? Or is there some kind of underlying chronic condition? And I want to suggest that part of our role as well is to disclose risk and or potential risk to residents and or their substituted decision makers. And I want to suggest in the ethics language, the ethics literature actually supports this, that it's not enough for us just to disclose the risks, that actually as healthcare providers, it is our role to foster and encourage understanding of risks. The example is of the compliant or the seemingly compliant resident, particularly somebody who might be older. I know myself, when I go visit my physician, and I know that I only have 15 minutes in there, and I can only talk to her about one thing, even though I've got like 3 or 4 things that are wrong with me, like there's parts falling off, but she's rhyming off these things in medical language as if I know exactly what she's talking about, and I'm sitting there either, thinking about the other things I want to talk to her about, not quite understanding, but I'm not asking any clarifying questions because I really want to get to the other issues. So, did I really understand what she said? Or am I just being compliant? Or are there other pressures that I'm facing, i.e. time crunch, and being conscious of others because I'm a Scot and I come from a long line of Scots who are really conscientious about other people's feelings and thoughts. And so I don't want to inconvenience my physician. And so just because somebody agrees doesn't necessarily mean that they understand. And so I want to suggest that our role as healthcare providers in long-term care is to assess for risk, disclose relevant risks, and to foster some kind of and encourage understanding of these risks. I also want to suggest that our role is to contribute to effective team function. So when we are having difficulties with risk or assessing risk with a particular patient or resident, whether it be about food, what they can actually swallow or what they can actually intake, or whether it be for falls, that we are actually using a similar kind of language and that we're effectively communicating with each other and we clearly know what our roles are. That our role is to bring issues forward. Any changes that we might see in Fred related to his ability to be able to swallow. And that we engage respectfully with other people's views. That we don't just dismiss somebody because we don't necessarily like working with them, or we don't necessarily like the culture that they come from, or we don't necessarily like their interpretation of risk, and that we be willing to consider alternatives, and that we participate in an evaluation of the care plan or interventions or team functions or the situation. So this leads me to another one of the objectives, which I call the 5 fingers of choice, or in ethics language, the 5 fingers of informed choice. And within Capital Health, we have a brochure that describes these, so it's something you can tuck in your pocket, you can give to patients. There was a pilot project that I was involved with a number of years ago in long-term care. It was actually at the Veterans, where a group of people on a quality committee developed a brochure in a language for residents and or their family members around the 5 fingers of decision making, or the 5 elements of decision making. So the index finger is capacity. That has to do with the ability to make intentional decisions according to a plan. The middle finger is disclosure, and disclosure has to do with providing adequate information or having adequate information upon which to make decisions. And I'll talk a little bit more about each one of these. Understanding is the ring finger. It has to do with the ability to understand and assess the information that was disclosed and to consider alternatives. Voluntariness is the baby finger. It assesses the influences that control have over the decision. So voluntariness, I'm going to pause on that. I'll say that for when I talk about these a little bit more. And then the 5th finger is actually our thumb, and it is the actual choice. And the choice has got to do with the authorization or the